Good afternoon. Welcome to everybody who's joining the talk today, and my apologies, slight technical issues there, but welcome. And I'm Glenn Morris. I'm the director of the Emerging Pathogens Institute at the University of Florida. We are very pleased this afternoon to have Dr. Tom Hladish speaking as part of our ongoing COVID-19 seminar series, COVID-19 vaccine seminar series. Dr. Hladish is a research scientist in the Department of Biology and is a part of the Emerging Pathogens Institute here at UF. He has been called upon by the Florida Department of Health to advise on its COVID-19 response. He's an expert in infectious disease dynamics and intervention. He has developed statistical modeling models, statistical forecasting models to help DOH plan for healthcare needs, predicting which counties are likely to have greater need based on age structure and risk of severe outcomes, and when the Army Corps of Engineers should build temporary health facilities. He's also worked with DOH staff to help them better understand predictions from COVID-19 models developed by various research groups. Over recent months, he has dedicated himself to studying models and data related to the outbreak and working with journalists to improve the accuracy of science communication. He's been interviewed and quoted by national news outlets such as the New York Times, Wall Street Journal, CNN, and Vox, and local syndicates including the Tampa Bay Times and National Public Radio's member station, WUFT-FM. We're very pleased to have him today, and at this point, I will pass things on to him, and we look forward to hearing your talk.
Thank you, Glenn. That was a very nice introduction. So I'm going to be talking about COVID-19 vaccination for the state of Florida, and I noticed that there's a little bit of ambiguity in the title here. I didn't capitalize the S in state because this is modeling of the state, but this is not work that I did for the state, because I've done both at this point. I'm going to start at the end, and the reason why I'm going to start with the conclusions is because I think that in general modelers have not done a great job during the COVID pandemic with communicating what we do when we don't know. As a simple example, back in last March, on March 16th, the Imperial College of London released a white paper saying that in a scenario, 2.2 million people were going to die in the US. And of course, that didn't play out, and it affected the credibility of modelers around the world, which is kind of silly because if you actually read the paper, they said that that's what might happen if there were no interventions at all. But you know, once you start talking about numbers and details of models, it can be easy to get lost in what the meaningful conclusions are versus what stuff is just noise. So, conclusions. The main benefit of vaccination in Florida will be prevention of death and severe disease among vaccinees. And the reason for that is that this campaign is too little and too late. We're already in the midst of a very large winter wave, and it's going to be, we can dent the transmission that's going on right now, but we can't stop it. And I think that by the time this winter wave is done, we're not going to see any more transmission for about a year and a half. And so the vaccines will be able to prevent future waves. You know, and my best guess is the next one will happen in 2023. But right now, the main reason to get vaccinated is because of the direct benefits to people who are vaccinated. One important caveat or aside here is that mutant strains could make this spring much worse. And of course, there are mutant strains. The UK B117 strain has been introduced in Florida and it's circulating. I don't know exactly, you know, I don't know how long it'll take for that to become really widespread, but it has the potential to make this current wave quite a bit worse. Okay, so now let's dig into all the details. What can vaccines potentially do? So we typically focus on the benefit to the vaccinee. I think that that's kind of intuitive. That's how we usually think about vaccines, that they can reduce mortality and symptoms. But as an epidemiologist, I think about the population most of the time, and that's really what I'm interested in. because you can have benefits that go far beyond the individuals that you're vaccinating. So in this case, you can have reduced transmission given infection, which is to say you can break transmission chains that would have occurred otherwise. And by doing that, you can protect both unvaccinated and unsuccessfully vaccinated people. You know, the vaccine isn't 100% perfect. And so even vaccinated people can be protected by other vaccinated people in that they may not get exposed in the first place. The pie in the sky here is elimination or eradication, and some people are thinking about what you might do with vaccines in order to achieve that. I don't think it's realistic, but it's not on the table right now anyway. We'll have plenty of time to think about that in the coming years, how that might be achieved. And then, in addition to the direct health consequences of vaccination, there can be a benefit to the public health system, and you can reduce the economic and social burden of dealing with the pandemic, because obviously we've all been dealing with that as well. I'm sorry, there's a message that says I should unmute. Am I muted?
No, you're good.
Okay. Good. Sorry. Okay, so everyone wants a crystal ball, and the state of Florida certainly did as well last spring and last summer. In order to make predictions using transmission models, there's quite a bit we need to understand. We need to understand a lot of details about the population, the demographics, so that's the age distributions. We know with COVID, it's important what comorbidities people have. That's something we need to understand. The spatial structure of populations, we've seen that in some cities, we get a lot more transmission, like, of course, New York City got hit really hard and early. Within Florida, the southeastern part of the state, Miami-Dade and Broward counties got hit particularly hard. So we know that there are some, maybe some density dependence or other spatial structures that are really important. Interaction patterns between people are super important. Some of us have hardly left the house, and others have not really modified behavior at all. And then those behaviors have changed over time too, and I can show you some data backing that up. And then finally, of course, there are non-pharmaceutical interventions. There are whether it's the plastic shields that are up in front of checkout counters, or school closures, non-essential business closures, et cetera. We also need to know a lot about the pathogen, the probabilities of different outcomes, how long it takes for certain things to happen. Once someone gets infected, what's the distribution of times until they develop symptoms? Because typically people haven't gotten tested until they're symptomatic, and so that period of time is really important in terms of managing a pandemic. And then finally, with regard to the vaccine, and in some ways, this is we know the most in some ways about the vaccine because we've had trials to evaluate the efficacy of the vaccine. We need to know how quickly it works, what outcomes it prevents, and how long that that efficacy lasts. So digging into vaccine efficacy a little bit, so there are several different kinds. The one, I don't think I can highlight the text here, but the third point here, I'm going to start there. This is vaccine against efficacy against clinical disease in those infected. That is the main outcome that was measured in the phase 3 trials. And so when you hear that the vaccines are, for example, 95% efficacious, that's the kind of efficacy we're talking about. We're lumping together infection and disease. But we can also imagine that vaccines can prevent infection with or without preventing disease. And then given infection, you can ask, okay, so someone had a breakthrough infection, they were vaccinated, they got infected anyway, what was the probability that they got clinical disease at that point? And the mathematical relationship between these is pretty straightforward. The important thing is what we observe in the real world is this thing on the left, VESP, but in terms of understanding the mechanism, we need to understand VES and VEP, because if we have a lot of people who are vaccinated and they are asymptomatically infected, they can be going on to transmit to other people. And so that's kind of a wrinkle with vaccines. It is plausible in principle that when you vaccinate a population, you actually get more transmission. I'm not saying that that's what's likely to happen here, but it's possible in principle. And then finally, there's also VEI. This is a vaccine efficacy against transmission. So VES is like incoming infection and VEI is like outgoing infection. And I'll tell you now, we don't know anything about VEI for these vaccines. These are some of the details of what we do know for 3 vaccines. Of course, the Pfizer and Moderna vaccines, those are the 2 main vaccines that are being used in the US. And we're also probably going to start using or seeing some use of the AstraZeneca vaccine. I don't know to what extent it'll be used within the US versus, for example, lower and middle income countries, because this is a substantially cheaper vaccine and easier to distribute. But so because in the US, we are focusing on these first 2, Pfizer and Moderna, and they have very similar profiles. They both have about 95% vaccine efficacy against disease. And both claim to be efficacious against the mutant strains that we're seeing. And so I'm kind of lumping them together at this point. I'm not making a distinction between the 2 because as far as we know, they perform very similarly. We don't have very much information about the vaccine efficacy against infection, but there's some based on, I think this was a neutralization assay that found, no, this was, these were positive swabs. So it's not quite the same as knowing for sure that someone was infected, but it's a pretty good proxy. So I'm assuming that about 60% of, that there's a 60% effect of preventing infections in the first place, and then we can calculate the probability that disease is prevented given infection. I'll come back to that in a minute. So as I mentioned, we typically just focus on the direct benefit to vaccinated individuals, and there are scenarios where that is what is most important. So for example, in the middle here, we have vaccine only prevents disease, so transmission can happen anyway. And that would be a scenario where the vaccine is only helping vaccinated individuals. Or you could also imagine some sort of environmental exposure, for example, for rabies or something like that. That's not something that spreads person to person. And so the people who benefit are the ones who are vaccinated. Now, whenever we want to say, well, how good was the vaccine? How beneficial was it? We always need to compare it to a counterfactual. So that's this scenario that I have drawn out on the left here. That's the transmission that we would have seen without the vaccinations. And at the risk of stating the obvious, in the real world, we never know exactly all of these scenarios. There's always something that did happen, like we used the vaccine or we didn't, and we can't know the alternative, the counterfactual. And so that sort of leaves the door open for modeling to step in and give us helpful insight. Otherwise, we have to rely on sort of natural experiments. You know, one region that did vaccinate, one region that didn't, and compare outcomes that way. And so, just to strengthen this metaphor, you know, you can think of this scenario on the right here as everyone having an umbrella. If you have an umbrella, that doesn't prevent people around you from getting wet. But I think that the more, from my perspective, the more important, the more interesting benefit of vaccines is that they can prevent onward transmission, and then they have this sort of amplified effect that depends on what fraction of onward transmission they can actually disrupt, and as also how infectious the disease was in the first place. So, you know, I have a little cartoon here that shows that the vaccine the pathogen still spread through part of the population, but onward transmission was then disrupted. So there was a benefit at the population level. So if you want to know what the overall benefit of a vaccination campaign is, it's the sum of these two things. There's the direct benefit from vaccinated individuals, and also the indirect benefit of toward others who are not successfully vaccinated. Now, we don't have to do very complicated modeling to say something about what kind of level of vaccination in the population we would need in order to prevent or shrink an epidemic. So this is a little bit complicated because if you don't have an epidemic currently, then what we're talking about is preventing one. If you're in the midst of one, then the question is, what would it take to get the reproduction number below 1 so that the epidemic stops growing, basically. And so if the only tool you have is vaccination, then this is what we're looking at in this figure too. So, we can look at the 90% curve here because that's the closest value in this figure to the Pfizer and Moderna vaccines. If we say that COVID has a basic reproduction number of 2, then we can trace that curve up until we hit the yellow line, and then you go over and you see that you would need to vaccinate about 55% of the population in order to prevent an epidemic. Now, this approach, you can do this basically on the back of an envelope, and one of the reasons for that is it assumes a homogeneous, well-mixed population. So everyone's like everyone else, everyone has the potential to interact with everyone else. Those are obviously ridiculous assumptions. That's not how the world works, but this still gives us sort of a starting point of what we should expect. Now, one thing that I think is important here and has been missed by some people who have been, some experts that have been quoted in the media recently, is that natural immunity counts too. At this point, a lot of people have been infected. And so if you have a certain level of natural immunity in the population, that brings down the critical vaccination percentage. You don't need to vaccinate as many people in order to achieve the same benefit if some fraction of your population is already immune. It's not as simple as just adding those numbers up and getting here, because natural immunity has its own sort of efficacy. Some people are infected and they don't acquire protective immunity, other people do. But the important thing is that natural immunity will tend to shift these curves downward. So what are the critical questions that we need to answer in order to try to make reasonable predictions of what's likely to happen? We need to know what amount of natural immunity is in the population, and so another way of putting that is we need to know what the cumulative attack rate is and how durable that immunity is. Cumulative attack rate is a bit of jargon. It just means the fraction of the population that has been infected at this point in time, and that should, we would hope, basically match seroprevalence, or the fraction of the population that would test positive with the serological test, but they don't always match up because some people don't acquire effective immunity. And also the serological assays are complicated because we don't know always exactly what we need to look at in order to say that someone is immune, like what threshold or what component of the immune system is most important. We also need to know how much transmission is really happening. If we have not had an epidemic yet, I like to think about the spreading pathogen like a spreading forest fire or something like that. If you hose down all of the trees, then you can prevent the epidemic from happening in the first place. But if you already have a blazing forest fire, then the same amount of water is going to have a somewhat diminished effect, because some transmission is going to continue to happen before the vaccine is fully rolled out. We need to know what will the vaccine rollout look like. We know, we're in the midst of it now, but we don't really know how it's going to change, and that can have a big effect on the epidemic dynamics going forward. And then we also need to know what's going on with the mutants. Like I said, the vaccine manufacturers believe that the vaccines will be effective against the mutants. We don't know that for sure. I don't believe that there's really solid like clinical evidence of that. I think that it's more wet lab based. Okay, so what do we need to know about the population? Well, just to drive home the point that we do need to know about the population, if you have a homogeneous population where everyone is like everyone else, then you get an epidemic curve that looks like something on the one here on the left. And that's obviously not what happened with COVID. What happened with COVID in Florida is this blue curve on the right. So what are the things that shaped that put us in this position that we're in right now? And a very important thing to keep in mind that has not been given enough attention and is hard to account for is how much detection and reporting have changed over time. So these are the numbers for Florida. On the left here, this is how much our ability to detect infections has improved relative to the first wave last spring. And so you can see that relative to the first wave last summer, we were detecting about 3 times as many infections. And now we're detecting maybe about 6 times as many infections as we were back then. Case reporting delays have dropped dramatically. In the beginning, some people, or I believe these are medians, the median reporting delay was a month. Now we're down to a few days, and if you've gotten tested at Florida, you've probably seen that, I've gotten tested several times now. I've always been negative, fortunately. I've gotten my results back in typically less than 24 hours, which is fantastic. If we could be doing that everywhere, that would have a huge benefit to our ability to manage the epidemic. Now, something really weird is that while case reporting the delay has decreased, the death reporting delay has increased. This is problematic because we really rely on deaths as a reliable metric to figure out exactly what's going on. And there are, I think it was the Sun Sentinel did a really nice piece on how death reporting delays have changed over time. And also how, I think it was on October 22nd, the state took over certification of COVID deaths from the medical examiners in the state. And one of the things that they found is that some deaths are not reported for 2 months after, for more than 2 months after the death actually occurred. And so when you're trying to, rely on deaths to figure out how big is the problem, what's going on, these delays are really complicated and problematic. We also know that behaviors have changed in Florida dramatically. So these are 3, on the right-hand side here, these are 3 different cell phone mobility data sets that are measuring different things. And you can see some things in common between them. In late spring, there was this precipitous drop in activity, whether it was people's proximity to other cell phones in the middle here, time spent in or outside the home, and also regular commuting patterns. But then the way they've changed over time is quite different. So you can see in the middle, it's stayed kind of flat, but other things have, some of the other metrics have crept up. And, I find it helpful to see these pictures from what goes on outside my house, because I would not have believed it if there wasn't such extensive media coverage of people completely ignoring guidelines about mask wearing and things like that. So those things are important, and we need to take them into account. All right, so what do we do with all that? Our model, it's called an agent-based model because we actually represent individuals, has people that can progress through these states here. So susceptible, exposed, and a number of different infectious compartments: asymptomatic, mild, severe, or critically infected. And then people who are critical can either die or they can move back to being mild, and then they can recover. The amount of time people stay in these states is probabilistic based on a number of different data sets. In some cases, we've had to just make our best guesses based on limited data. Outcome in the model, so whether someone is severe, critical, et cetera, that affects detection, but it does not directly affect infectiousness. It indirectly can affect infectiousness because it can affect people's behavior. Detection probability and lag are time varying and depend on outcome. And we also have age and health dependent outcome probabilities. We have a really nice data set from the CDC on how age and certain comorbidities affect outcomes. And we have that data, I believe, stratified by county for the entire state. And then we assume that ICUs reduce mortality. And also that there were clinical improvements that happened last summer, particularly, for example, increasing the use of dexamethasone, better understanding of how patients need to be positioned in bed, using oxygen sooner, using vents later. So we incorporate some of those changes in the model. We have natural immunity in the model where the starting point when someone gets infected is log normally distributed. And that's based on this paper that just came out by Dan et al. That shows, so if you look at, for example, they show similar patterns, but if you look at panel F here, the starting points on the left, these dots all represent different individuals. And so some people start with a lot of immunity, some people start with very little immunity. Whatever you start with, you tend to have a fairly consistent waning rate. So that's what we assume in the model. And then when people drop below a certain threshold, they become susceptible again. And so the distribution of immune durability in the model is what you see in the bottom left here. Some people do not acquire effective immunity, but the mode here is around a year. So most people acquire immunity for a pretty long time. This is sort of a heat map of where the locations are in our model. We're representing 20.6 million people, 9 million households, about 8,000 schools, 4,000 long-term care facilities, 307 hospitals, 2.3 million other workplaces, aside from those listed above. And then we also know what type of workplace every workplace is. We actually have latitude and longitude coordinates for every workplace, and we know which ones are designated essential and non-essential. The households are just sampled based on basically a density map of the state using household compositions from the long form census data. And then we also sometimes work with subpopulations because this is a pretty big model, 10 gigs of RAM. It takes about 8 minutes a year to run it. We have lots of different data sources, census, Agency for Healthcare Administration, and well, there are these and some more. I'm not going to read through all of them because it's probably not that interesting to you. And so then people have to get associated with locations, and we use a set of sort of probabilistic rules that are based on gravity models. So gravity model just means, in a sense, the closer you are to something, the stronger your relationship with it is likely to be. So people are more likely to go to a workplace that is close to where they live. They're also likely to go to a workplace that's bigger. So we assume that workplace sizes are Pareto distributed based on work we've done in the past. So we sample workplace sizes and then we assign people to workplaces. Students go to the closest school that's an appropriate grade range, except for higher education. For the higher education institutions in the state, we actually looked up what enrollment was and work with those numbers because it would be kind of embarrassing if the enrollment numbers for UF were a small fraction of what we know them to be. People are also associated with hospitals. If they get sick, there are certain places that if there's a particular hospital they'd go to. And then we have inter-household connections. And those are probabilistic based on household size, and I glossed over this point, but households also have compliance scores that we sample on 0 to 1. And that's just, you can think of it like people's tendency to take precautions to prevent transmission. And the reason that we consider that when making connections, well, the short version is that if you think about who you know and who you interact with, those people probably have similar masking behaviors to your own. I talk to my neighbors out in the yard and we're all wearing masks, and then you see other people who are complete strangers going to bars and none of them are wearing masks. So we tend to assort with others who have similar levels of protective behaviors. These are just some, here's a heat map here showing you where the households and workplaces are. And then we have worker movement. Most worker movement is very short distance, and that just fills in the urban areas here in solid blue. And then we also have some long distance movement. That would be the main mode of transmission over longer distances. Here's just to give you a sense of what this looks like. So here's in the view of part of Miami in the model. The gray dots are households, the blue dots are workplaces. You can see that because we know the locations of workplaces, they actually fall on streets. And then here's a particular household, that we're highlighting here in this fuchsia color. This household interacts with one other over here. This is the hospital in this red circle that they would go to if they're very ill. And then they have a workplace and a school, and this is the demographics of the people here. So there's one person with a comorbidity and two people who are healthy. So then what do we do with all of those locations? They're basically the different transmission settings. We can have within household transmission, between household transmission, workplace, hospital transmission, and also transmission in long-term care facilities. Okay, so what are we assuming about the vaccine? I mentioned, it looks like maybe I don't have I mentioned how we have to calculate this 0.875. So the 0.95 here, this was the primary endpoint of the phase 3 trials. We have some evidence that the protection against infection, this S stands for susceptibility, is 0.6. And so you can work backward and figure out what the protection against disease, this P stands for pathogenicity, is. And so these are the assumptions that we're working with. And we're assuming that efficacy kicks in after 10 days and that it's durable. And that 10-day effect is based on the Pfizer phase 3 trial paper that shows that in the vaccinated group, they essentially achieve full benefit of the vaccine after dose 1, after 10 days after dose 1. And that's basically where this the brownish line here departs from the bluish placebo line. And these data are, as far as we know, consistent with both mRNA vaccines.
Tom, just to clarify, go back a slide if you would. Again, I would just, based on one of the questions we got, what I would emphasize here is that as you show, the curve breaks at about day 10, 12, 14.
Yeah.
What Pfizer did do in their paper was publish a efficacy rate, in the first 3 weeks of 52%. And so the question was asked, what does that mean?
Yeah, so the issue there is they're integrating over this whole period, and they're including this first period when the vaccine is not beneficial. So when I say we assume that 95% efficacy occurs after 10 days, that is what they're showing here. But if you were to integrate over that entire 3-week period, you come up with 52% instead. And it's because like I said, they're including this period with no efficacy with the period once efficacy has been achieved.
I might just add, if you look at the data that came from the other trial, the other mRNA vaccine, can't talk straight here, that they actually broke it out in day 14 through day 28. And that time period, again, showed a very clear 95% efficacy. Okay, so, again, I think there's some people keep saying, well, it's only 52% after the first dose, but I do think it needs to be recognized that you do kick in after about 2 weeks.
Yeah, so I think the problem there, this kind of gets back to, I think that's what's in the caption of this figure actually is the 52%. And so, yeah, when people just read one number like that, they can make incorrect conclusions about what, like in this case, what the long-term efficacy actually is. Okay, so campaign assumptions. We assume that the campaign starts at the beginning of this year. and that the campaign will go until 50% of the population is vaccinated. That's just a number that I've made up. I think we're going to see, right now we see a lot of interest in the vaccine. There's more demand than there is supply. But of course, there are a lot of skeptics. There are a lot of people who aren't willing to get vaccinated. And so there's this complex interplay between how much is available, what kind of PR campaign there is to convince people to get it, and then what people's sentiment is about the vaccine. But this is what I'm assuming here is the campaign will go until 50% of the population are vaccinated. We're assuming that first we vaccinate 65-year-olds and older, which is essentially what we're doing. In reality, it's the older population plus healthcare workers, long-term care facility workers, things like that. But in the model right now, we're just focusing on the older people. And then once you achieve 50% coverage in that population, then you work on achieving 50% coverage in the 16 to 64-year-olds. I guess I should point out that it's not 50% coverage of the entire population, it's 50% coverage of the population that is currently being considered for vaccination, which are 16 and over. And so I'm looking at two different distribution rates. One, this is as of, I think last week, we were vaccinating about 0.12% of the population per day. But the Biden administration has said that they really like the number 100. They want to hire 100,000 people to distribute 100 million doses in 100 days. And that ends up to being about 0.3% of the population per day. So when you plug those in, this is basically what you get here. So let's look at the bottom left. This is the thing that people are probably most familiar with looking at. These are the number of cases per day over time. And so initially we just have this green curve, and because all of the lines are plotted on top of each other because there's no vaccine. And then once we get to January 21, we have this divergence of the green, the blue, and the black curves. So this basically shows that the wave that we're in right now, I think that we are basically at the peak, assuming now this is a no mutant strain scenario, and I'll relax that assumption in just a moment. But if we assume that transmission basically continues the way it has been, I think that we're essentially at a peak, and that will run out roughly by this summer. Vaccines make that happen faster, essentially. On the right here, we have the death incidence, and it's a very similar shaped curve. Now, one thing, these are in case some people are familiar with time-varying reproduction numbers, so I included that for our model in the top left here. Now, one thing that you might be saying is, well, this doesn't quite look like the epidemic curve in Florida that we've had. There's a spring wave and a summer and a fall wave, but the wave we're in right now is about the same height as the summer one, and this is a stronger peak than what we actually saw in the spring. And I'm going to argue that that is all due to reporting. So when you take this and the top, this is what the model actually has in terms of cases per day, and then you filter it through these our time varying case detection and reporting lag models, then what you get is this thing on the bottom. So the black curve is the empirical data we have, and the blue curve is one run of the simulator showing how you have to really think about this observation process. So I like to I think about understanding epidemics from a public health perspective. You really should think in terms of a transmission process, an observation process, and then reported data. Sorry, my kids are home and they are looking for food. That I just wanted to explain why this is not quite the same as what you would see, for example, on the DOH dashboard. Okay, so then to quantify this, like I think it's helpful and intuitive to look at those curves, but to quantify it, we have a couple of different ways of doing that. One is talking about effectiveness. This is different from efficacy. Efficacy is really the individual level benefit. Effectiveness is what is going on at the population level. This is sometimes called overall effectiveness. And so it's basically in the numerator here, it's how bad was the epidemic given the intervention, given the vaccine, relative to how bad it would have been without that intervention. And then you subtract that from 1 to get how much, what the improvement was. So this is a number on 0 to 1 that basically tells you how much of a certain outcome, cases, deaths, whatever, were prevented. It's also useful to think in terms of cases averted sometimes. So that's just the difference instead of the ratio of these things. So it's basically how many cases were prevented or how many deaths were prevented. And if you want to know like economic impact, thinking in terms of QALYs or DALYs or something like that, this is probably the approach that you would use. So I've added those panels to the bottom here. So the top 3 panels are what we just looked at. This is cumulative cases averted and cumulative deaths averted in row 3. And you can see that with the faster rollout, which I think is not absurd. What the Biden administration is aiming for, I think, is probably feasible. We're already seeing a faster rollout this week in Florida than we had a week ago. That would put us on this green trajectory here, which means that basically about 30% of the cases, the symptomatic infections that would happen in 2021 would be prevented by that faster rollout. For deaths, it's quite similar. It's about 30%. In terms of cumulative cases averted, so these are reported per 10,000, so you can compare between different population sizes if you need to. We're talking about approximately 100 symptomatic infections prevented or averted, and a bit over 2 deaths per 10,000 averted. I want to say one thing here about the use of the word case. I really don't like the fact that this term has been used and abused in a number of different ways during the pandemic. I think that most infectious disease epidemiologists would use the term case to mean a symptomatic infection. That is not how anyone in the media is using it. It's not how the health department is using it. They are using case to mean detected infection. But if you start detecting asymptomatic people, then it's not the same number. And if you don't detect all symptomatic infections, it's not the same number. So I just want to emphasize that here, I'm talking in terms of the actual public health burden. And so I'm talking about all symptomatic infections. Now, this is the nightmare scenario we may be looking at. If we have, the B117 strain has been observed in Florida. It's been detected several times. I don't know off the top of my head how many times at this point. If we assume that this new strain is 50% more infectious and that it will displace the existing strain gradually over the course of January, then this is the scenario that we're looking at. So starting with the no vaccine scenario, we had this wave here and it jumps up dramatically. And so this kind of opens the door, at least in terms of averted cases and deaths, for the vaccines to make more of a difference because there's more to prevent. But even with a pretty aggressive vaccine rollout, it's just not fast enough in order to really disrupt this epidemic. My best guess is that this scenario, that the reality is basically going to be somewhere between this and this. That the strain is probably substantially more contagious. I think that what we've seen in the past is if things get really bad, you start to see people modifying their behaviors more. And it's also possible that we're still overestimating just how much more infectious this strain is. The initial estimates were 70% more infectious, then it came down to 50% more infectious. It can be a little bit difficult to properly take into account people who may have lost immunity when you're trying to estimate things like this. So we'll just have to see. But like I said, I think the reality is somewhere in between this this more pessimistic and the previous more optimistic scenario. So some important assumptions and limitations about this work. We are assuming that there's about a 35% cumulative attack rate. We're assuming that the non-pharmaceutical interventions are not going to change during the next 6 months. We assume that seasonality is not a major factor. We know that coronaviruses do tend to be seasonal, but thus far, you know, we had a big wave in the summer, and so this is contagious enough that I think other factors tend to trump seasonality, but it may end up being important going forward. So, you know, sort of how this current wave gets curtailed. And then we're assuming, as the manufacturers are asserting, that the vaccine works against the mutant strains. So these are the conclusions. You've already heard all of them. And so I will thank you and the many people who have helped me with this work. I'm happy to take questions. You're muted, Glenn.
I'm sorry, little problem there. Tom, this is a question that several people ask. Is there information on whether the vaccines will need to be administered every year similar to the flu vaccine?
I'm sorry, I just saw the question about why am I blurry. That's an excellent one. Do you mind repeating that?
Is there information on whether the vaccines will need to be administered every year similar to the flu vaccine?
I think that the short version is no, we don't know anything like that, because in order to say how quickly immunity wanes from the vaccine, time has to pass. You know, we don't have like weathering chambers where we can, like in material science, where they can make time go faster with harsher conditions. So the only way we'll really know how durable the vaccines are is by letting time pass and watching what happens to vaccinees.
What's the assumption for the percentage of Floridians who have been infected with COVID?
So I mentioned that that's the cumulative attack rate. That's 35%. And that's something that we have spent a lot of time looking at and thinking about. A lot of people have opinions on this based on serological data and what you think the infection fatality ratio is. The problem is those numbers are also uncertain. So for example, there's a study that recently came out of Imperial that estimated that the infection fatality ratio in high income countries was 1.15. There's a study that was done in Florida that suggests it was 0.25. I talked to colleagues at London School who estimated what they think it is for Florida, and they said it's not more than 0.76 and possibly as little as a third of that. So those different estimates really create a lot of uncertainty in what you think the cumulative attack rate is. But our best guess right now is about 35%.
Okay. How were between household connections identified? Is this coming from the case data?
Between household connections, that is just a simple probabilistic model. We assume that households that are near to each other and large and have similar protective behaviors are likely to interact. And then if they are adopting those protective behaviors, then they choose not to interact on a given day, basically. So we don't have empirical data on what those interaction patterns really should be.
How are reinfections represented in your model, and how will new strains affect that?
reinfections are just like initial infections. So most people are immune for the durability of the simulation to reinfections, but some people do get reinfected. And if they do, there's no change in the expected progression.
Okay. Are you assuming that there will be no shortage of vaccines?
Not exactly. You know, we have pretty good evidence that the manufacturers, I don't remember the numbers exactly right now, but I believe that Pfizer said they thought they could deliver 200 million doses by the summer. And you know, those are the numbers that we're talking about, is that between the two manufacturers, I don't think that there will be any shortage by the end of the summer in getting everyone who wants to be vaccinated, at least with one dose. So I'm assuming that the limitations right now, and this is what we have observed, the limitations are logistic. You know, most of as far as last I checked, this is still the narrative I'm hearing, is that most of the doses that have been distributed to you know, to hospitals, et cetera, have not been administered. And so the problem right now is not an availability one, it's a distribution and logistic problem.
Okay, switching a little bit over to, you know, the school systems. Do you have an update on a child vaccine and when that might be available? I have a high-risk child, and based on your presentation, most adults, including teachers, but not children, are vaccinated. Is it reasonable that the risk to my child is much, much lower to attend brick and mortar school come the fall of 2021?
I don't know the answer to the first part of that, but I am comfortable saying in the answer to the second part that it should be safe to return to school, simply because I don't think that we're going to be in the midst of an epidemic wave at that point. I think that by the end of this summer, we will have seen so many people infected in Florida that between the infections and the vaccinations, I think that we'll be well above the herd immunity threshold. And so that's the kind of indirect benefit that I was talking about at the beginning. You know, I hope that that the vaccine manufacturers sort out whether the vaccine is safe for kids. I have 2 school-age kids myself. I don't have any inside information on what the likely availability of such a vaccine is, but my hope is that it will get sorted out by this fall, but also that it won't be necessary.
Okay, actually, back to the issue that I had noted earlier in your talk about the time till one begins to see protection. This efficacy after 10 days does not seem to be used by UF Screen, Test, and Protect. I believe they are using a time frame of 2 weeks after the second dose for things like no longer requiring campus clearance, routine testing, etc.
I think that is, you know, maybe that's a question for you and Mike Lizardo, but I think that is the sort of maybe the more conservative interpretation of the phase 3 trial data. You know, at the risk of stating the obvious, I am not determining policy, and so my job as a modeler is to make the assumptions that I think are the best reflection of reality. But once you start talking about actual policy, you know, there are legal implications there. You have to be able to back up the assumptions that you're making and say, look, this is what the manufacturer says, and that's what we need to adhere to. So I think I don't actually think that there would be any disagreement between, for example, me and Mike Lizardo on this point. But there's a difference between a model in the computer and the university's policy.
Okay, and probably time for one more question. Let's see. Questioner says, thanks for the presentation. What would you like to see changed from current practices for data collection and testing to make these models stronger?
Oh my God. I would love to know why people are getting tested, because this is one of the big challenges. When we're trying to interpret the available case data, you need to know, was this person asymptomatic? Were they tested because it was part of a routine screening? Was it part of contact tracing? The reasons for testing have a huge effect on how you interpret the reported case data. All of that stuff just gets lumped together and dumped out by FDOH, and we have to make some really broad, strong assumptions about how to interpret it. Similarly with deaths, I have been trying to find out for about a year exactly what the protocol is for certifying a death. My understanding is that if a PCR test was done while the person was alive, they simply rely on that result. We know that PCR tests are not equally reliable during the entire duration of the infection, and so a negative result doesn't necessarily mean that someone did not have COVID. The guidelines in the medical examiner literature is that we should be doing lung biopsies or lung necropsies in people suspected of COVID. I do not believe that the state has ever been doing that. And so if we have someone that is a suspected COVID death, but we don't have a PCR test done while they were alive, what is done is a nasopharyngeal swab of the corpse. And I have tried to find out how reliable those are, and the best guess is they are not very reliable. And it is totally absurd to me, but the best data we have on that is from the ophthalmology literature, where they've actually looked at a number of different tissue samples and whether they test positive post-mortem among eye donors. There's very little, those are really small data sets though. And so the state has just not been transparent about who they're testing, how they're testing, and so we have all of this data, and we're having to guess at what it really means in many cases.
Okay, we are basically out of time, and actually I've still got a long list of questions. I apologize to those whose questions we did not get to. But Tom, do you have any last words you would like to say at this point?
Boy, I mean, I'm in this with everyone else. It's exhausting. I just have to implore people to continue wearing your masks. If you're getting together, do it outside, and get vaccinated. Yes, the vaccine has some side effects. Yes, occasionally there are severe outcomes among people who are vaccinated, but the probability of those things is so much smaller. We're talking about orders of magnitude, hundreds or thousands of times less common to have severe outcomes as a result of the vaccine than to have a severe outcome as a result of COVID. There's a quote recently from I believe it was a pulmonologist who said that the lung x-rays that they've looked at for asymptomatic COVID infections are worse than what they see among smokers. So, it's a dangerous virus. I think that in general, people are still underestimating how much damage it can do to people who don't die. And so, yeah, I would just implore people to, maintain your sanity, maintain your mental health, but be responsible with your interactions outside of your household.
Okay, we have basically hit the 5 p.m. line, so I'm going to call things. Again, I apologize. There are a number of additional questions out. I assume Tom, I can volunteer you and say that if people wanted to email you or contact you directly with questions, that would be fine. And again, my thanks to everybody for joining us for the talk today, and we will keep you posted. I'm hopeful that we will be able to continue to have lectures within this series on COVID-19 vaccines as we move farther into the time period where we are seeing increasing rates of immunization and are seeing other vaccines come online. So stay tuned. Thanks a lot for your participation today, and stay safe.